how did that happen to go from the ICU to sleep doctor?
Well, when I started on my journey toward, actually becoming an attending, right? And you dabble, you always have the umbrella of being a fellow and having an attending who ultimately makes those decisions. Then you become the big bag of attending. You're going to make all those decisions yourself. One of the opportunities I had out of sleep fellowship, because it's pulmonary critical care is one fellowship and then sleep is the other fellowship. Once I was done with all of that training, I honestly, after that year of sleep, I was like, I still love the ICU because of the intensity and patients are interesting and it feels really good and rewarding when you can save a life. I mean, that's kind of like a high. You know what I mean? Like you feel really good about yourself. But I really loved sleep. And I had the opportunity to build from the ground up a program. And as a young female physician being given the opportunity, you are sleep fellowship trained. We want you to build a program that we do not have. In New Jersey,
Where was this?
This is in New Jersey. There's an unmet need for that. And I ran and built that program, and it was an amazing learning experience. I mean, literally, it started with just me. And by the time I chose to transition away from ICU medicine entirely, there were about 8 sleep providers at the time at my particular institution. So the transition for me really was about a chronic accumulation of, and we alluded to this earlier, but to circle back to the question of my insomniac issues, I would spend 3 to 4 weeks, depending on the call cycle, really not getting paged. I did my work. I had a very busy practice. I would go home, spend time with the kids, and that was that, right?
Mm-hmm.
But then I had my week of 24/7 ICU call.
Mm.
And I had been doing that for a very long time at that point. If you include all the residency training and everything, we were, getting it nearing close to almost 20 years of doing that. That takes a toll. It is very difficult to get paged in the middle of the night and with residents who had different comfort levels and being able to explain what was going on. I'm the attending. I'm the final say. I need to make sure that patient is stable.
Right.
That may mean looking at my blue light computer to go over labs, look at imaging, whatever it might be necessary, potentially driving back into the hospital to manage an emergency, and then being expected to show up the next day and work a full day.
Right.
And if you do, so if you do that for 20 years, you're tired. And then you go into the pandemic and it being in New Jersey, anybody in New York and New Jersey, we were wave number 1. We were the guinea pigs. Let's just dump a serious disease that's spreading like wildfire, that we don't really fully understand all the components of it, and you manage it. I mean, it is difficult enough on one call cycle, that 7-day call cycle, to have one ARDS patient, adult respiratory distress syndrome. That's what COVID caused. It's inflammation in the lungs. Imagine having more than you can possibly imagine. And it was not all hands on deck. It was, you've been picked, you've been picked, you've been picked, you're going in. We have older people, they're not comfortable going in. We have people at different hospitals that don't have privileges here, so they're not coming here. We need people to man the office, they're not coming here. You must do this. I was told what to do. I'm an employee.
Right. Yeah.
So I showed up, I did what I had to do, and that included an overnight call schedule. And I was not asked if that was a schedule that was conducive to me or that was something I wanted to participate in. You were going to take a 12-hour overnight call. 12 hours on, 12 hours off. That's what you were going to do.